90% of the couples conceive normally. Only the remaining 10% of the couples usually go through infertility, and azoospermia is one of the causes for male infertility. Azoospermia means absence of sperms in the semen. Person will be able to ejaculate the semen, but there won't be any sperms inside that. So in that case, of course, after the initial hormonal evaluation and all that, so when a time comes that we have to look for any sperms inside the testis, then we do various surgical sperm retrieval techniques. Number one is the PESA, P-E-S-A, percutaneous epididymal sperm aspiration. Number two, TESA is testicular sperm aspiration. Number three, TSE, T-E-S-E, that is testicular sperm extraction. And the last and the most advanced is the microtesse, microscopic testicular sperm extraction. So what we do is, of course, all this is done under anesthesia. First, during the clinical examination, if we see a turgid epididymis, then we usually do a PESA first. PESA is, like I said, percutaneous epididymal sperm aspiration. A patient is given anesthesia, and then we take a insulin syringe and which is filled with the media solution, and then we prick the needle into the epididymis and then we aspirate, and then the aspirate is sent to the embryologist in the IVF lab, who will examine for sperms in the pellet. And then if sperms are found, they use it for the IVF ICSI. So that's how the PESA is done. The next is the TESA, T-E-S-A. TESA is basically we take around 20 gauge butterfly needle, which is connected to usually a big syringe, which is around 50 ml syringe, and then we prick the needle into the testis. Again, all this is done under anesthesia. The patient will not experience any pain. So needle goes inside the testis, and then another assistant will apply pressure and pull the piston, and then the needle is slowly retracted out, wherein you can see this seminiferous tubules coming out. And then we take a forceps and pull these seminiferous tubules out, and then we put it in a petri dish, and then we give it to the embryologist. So if none of these two techniques show any sperms, then we move on to the TESE, wherein we make a 3 to 4 centimeter incision on the scrotal skin, expose the testis, deliver it out, and then on the testis we make a 1 centimeter incision, and then the tubules protrude out, and then we use a scissor and then we excise a bit of that, and then that entire tissue is given to the embryologist. The difference between TESA and TSE is, in the TESA it's only a needle prick, whereas in the TSE we make an incision on the testis to take more tubules. So even if TSE does not reveal any sperms, and the final and the most advanced, the most complex procedure would be the microtesse, microscopic testicular sperm extraction, wherein now the testis is already opened because of the TSE which is done. We extend the incision on either side of the testis, and we completely open the testis, and we dock the surgical microscope. Under the surgical microscope, we look for any big dilated seminiferous tubules inside the testis at different planes. If we find any dilated tubules, so those tubules are selectively picked up and then they are given to the embryologist. Again, we pick up these dilated tubules from multiple places, maybe sometimes 5, sometimes 10 places and at different planes, and most of the time we are able to find sperms, and which are further used by the embryologist for the IVF ICSI. So this is in brief about the various commonly done surgical sperm retrieval techniques. If you are going through azoospermia, please do consult an dedicated andrologist to explore these surgical sperm retrieval techniques.